Hey everyone, Vicky from NP Reasoning here, bringing you some more diagnostic reasoning and testing pearls. Today I'm going to be talking about likelihood ratios. I'll be skipping over all the mathematical equations and formulas because, let's be honest, it can get a bit confusing. I'm going to cut straight to the chase with clinical applicability and just how we practically use likelihood ratios when we're working through a case. Before we move on, if you need to refresh yourself on sensitivity and specificity, I do have a YouTube video specifically on this, so check it out. But just to recap here, so if we're ordering a test with high sensitivity, that means that there's a low risk of false negative results. So high sensitivity helps rule conditions out. SNOUT rules it out. But if a test has low sensitivity, that means we run the risk of getting a false negative result. On the contrary, if a test has high specificity, that means there's a low risk of getting a false positive result. So a test with high specificity helps rule conditions in, spin rules it in. But if a test has low specificity, that means there's going to be a higher risk of false positive results and the issues that go along with that. So again, a recap on pretest probability. Again, separate video for this. Pretest probability is everything when it comes to diagnostic reasoning. Essentially, anytime we're working a patient up or considering whether we need to do more testing, we ask the following questions, right? What is the probability of X? If it's low, that means I've ruled it out or I haven't done enough to adjust the probability. If it's intermediate or medium, that's the sweet spot where we know more testing is needed to figure this out. If the pretest probability is super high, that means you're probably good. You've landed on a diagnosis and you're ready to initiate treatment. Second, you're asking yourself, have I reached the treatment threshold? If you haven't, you know you need to do more testing. If you have, then chances are you can pause and treat the patient and see if it works. Third, we're going to ask, will any test actually change my plan for management? If it won't, again, you can stop, pause. Will that test help anything? If the answer is no, then continue to treatment. If the test will change your management plan, then go ahead and initiate that. And then always weighing the risk benefit of a test, right? Is there more harm or is there more good? And then lastly, if I order this test and it's negative, is that going to make sense or am I worried about a false negative result? Second, and if I receive a positive test result, will that make sense to the clinical scenario I saw or is there a risk of a false positive result? So, where do likelihood ratios come in? Basically, they help us figure out how much a test result will actually change our suspicion that a person has or doesn't have a disease. So instead of saying, oh, this test is positive, this test is negative, LRs show how strongly that result points towards or away from a disease. In other words, it helps us delineate whether that test is needed before we order it. So we'll get into some case examples to illustrate exactly what I mean by this. First, positive likelihood ratios quantify how much a positive test result will increase your probability of disease. So, if we're looking at a test that has a positive likelihood ratio of over 10, that will majorly increase the probability of disease after you get that positive test result. But if we're ordering a test with a positive likelihood ratio of 1 to 2, it's not really going to change our probability of disease if we get that positive result. Let's make sense of this. So let's say you're seeing a patient with syncope, they fainted. One of your major differentials, of course, is cardiac syncope. So could an underlying cardiac condition or disease have caused that syncope? Because that's the most important condition we want to rule out, one of the most important. So you ask yourself, okay, I'm asking my history questions. Will asking about dyspnea really kind of change my post-test probability? Well, let's see. You're at this testing threshold where, let's say we have an intermediate pretest probability of cardiac syncope. Let's say the person fainted while they were exercising. That's a huge red flag. And now I'm going to say, all right, I'm going to ask if they were feeling short of breath before they had the syncopal episode. We know that just asking that history question, which is a test in and of itself, has a positive likelihood ratio of 3.5, which is decent. It might not majorly change your post-test probability, but it might marginally increase your post-test probability that this could be cardiac syncope. So let's say they say, yeah, I was really short of breath before I fainted. Okay, well, we know that should further increase our probability that this could be cardiac syncope. We haven't reached our treatment threshold yet. We're at the ongoing testing threshold where we need to do more tests, ECGs for the cardiac testing, labs, etc. But it just shows that that question alone as a test has a reasonable positive likelihood ratio that increased our post-test probability of cardiac syncope as a differential. Um, this where am I pulling these numbers from, right? Like the key thing is here we're not roguely memorizing likelihood ratios all the time, but sometimes I certainly look up what positive and negative likelihood ratios are for certain tests and certain diseases, especially when I'm in that spot of where I'm really questioning whether a test should be ordered. So the NNT.com is an awesome website that reviews things like numbers needed to treat, but also likelihood ratios. And they have this fairly interactive way of um, illustrating how negative and positive likelihood ratios influence your post-test probability. So as you can see here, what I pulled here was we're thinking of the diagnosis of cardiac syncope, and I'm asking that question, were they short of breath before the syncopal episode happened? Likelihood ratio about 3.5. So my pretest probability to start, about 50%, right? Intermediate range. That's just a guesstimation on your part, right? If I apply that question of shortness of breath and the person says yes, actually, supposedly, will increase my post test probability to 75%. So we're extra concerned for this patient. That question and the answer of yes, that positive likelihood ratio of 3 or 3.5 does increase the post test probability. So it goes to show it's an important history question to ask when we're thinking about cardiac syncope. And again, right, the NNT.com really emphasizes that your pretest probability is based on your gestalt, right? It's not a specific percentage, nor is the post-test probability per se. It's not a specific percentage. Again, this is where the nuance of diagnostic reasoning comes in, right? There's a lot of nuance, right? And it's not an algorithmic thing, and there's so much to learn. But thankfully, all these concepts keep building upon each other. So if you make that strong foundation, it'll all click into place, especially when you're seeing hundreds and hundreds and hundreds of patients. Flip side, what are negative likelihood ratios? Essentially, it quantifies now how much a negative test result decreases the probability of a disease or condition. So, conversely, a negative likelihood ratio less than zero point 0.1 will largely decrease your probability of disease. But if a test has a likelihood ratio between zero point 0.5 and 1, really won't do much to increase your post-test probability. So these are things to keep in mind, right? If you're thinking of ordering a test to rule out a disease, but the likelihood ratio is 0.5 to 1 and it's negative, again, it doesn't really help with your post-test probability in a meaningful way. Let's go to an example. So let's say you have a kid with, suspected, they have flu-like symptoms, suspected, viral URTI you're thinking about. One of your differentials is also pneumonia, though. They're, mildly febrile, they're not tachycardic, a bit of an increased respiratory rate. Yeah, of course you're worried about pneumonia, right? They're not super toxic appearing though. They're snotty. There's been a lot of viruses going around. They're pretty well appearing, and it's only been a couple of days. But we still ask ourselves, right? I'm still maybe a bit worried about pneumonia. Let's say you didn't hear any crackles in the lungs, but you're still thinking about it. It's on the, edge of your mind and you want to rule it out. You ask yourself, should I order a lung ultrasound, let's say, for a pediatric patient for suspected pneumonia? So let's say, for example's sake, my pretest probability of pneumonia is at least intermediate. Like it's a fairly unwell looking kid. I didn't hear crackles in the lungs, but I'm still suspicious. And so I'm still in this testing threshold where I haven't ruled it out or ruled it in, but I'm wondering, okay, should I order that lung ultrasound? Well, we know that lung ultrasound for suspected pneumonia in children has a negative likelihood ratio of 0.07, which is great, right? We know that it'll meaningfully change our post-test probability if the lung ultrasound is negative because it's a likelihood ratio of less than zero point 0.1. And it has a really good sensitivity and specificity. So good at ruling in pneumonia, good at ruling out pneumonia. we go ahead and apply that lung ultrasound, and there's no findings of lung pneumonia. So the question is, can I trust that result? Probably yes, right? Because it has a really strong negative likelihood ratio. With that negative lung ultrasound result, it's largely decreased our post-test probability of pneumonia. So for now, I've probably reached that treatment threshold, right? Likely a viral URTI, for example's sake, and I can send that person home, right, with conservative measures. So in essence, when we're looking at a positive likelihood ratio, um, we want to ask ourselves, will that meaningfully change our post-test probability if it's a positive result? Has that disease been effectively ruled in? But if we're looking at a negative likelihood ratio, if that result comes back negative, will that meaningfully rule that condition out and affect my post-test probability? So it's really good to look at those likelihood ratios, especially when you're confused, you don't know whether it's going to meaningfully change your post-test probability. So again, how are they helpful? Those situations where maybe you really aren't sure whether to order a test or not, and you're asking yourself, will this test actually decrease or increase disease probability? And again, in those situations, I'm looking that stuff up, right? We're not expected to memorize all of these stats, but we do the best we can. And the more we look up and the more we digest and reflect on our diagnostic reasoning and thinking, the more we'll understand what tests are good, what tests aren't good for certain situations. So key take home point here, LRs help us figure out whether a test will meaningfully change the probability of disease before ordering that test, which is very useful. All right, thanks everyone for listening today. All this content is on my YouTube channel. For more written content, weekly primary care updates, etc., please check out my blog, npreasoning.com. Thanks so much for listening.